I think that's one of the nice things about this particular disease state is that we have seen that. Maybe because the disease state is so homogeneous in how it's defined because of these doctoring effects leading up to it. So.
This is also a consistent theme across other clinical states, right? And your work in hormone-sensitive setting, the STAMPEDE studies, all suggest that agents that work in CRPC when given earlier are beneficial. In the CRPC studies with enzalutamide and abiraterone that are now several years old, we know that the patients with lower volumes of disease in earlier points along that spectrum benefited more from the therapy. It's not just that they lived longer, but they got a greater benefit from the therapy. I want to go back to my analogy of the patient with a PSA of 2 and say, yeah, the data probably do suggest that we should start darolutamide, apalutamide, enzalutamide at that point. But I wonder how many of us are jumping on it right at that time, or if we're giving the PSA doubling time to mature so that we can say, okay, now you're at the sweet spot where the PSA is 9 and the doubling time is 4.4, which is exactly what the patients on the study were.
Although there was probably 30 or 40% of patients that screen failed
because
by
they had
waiting
metastatic
to that
disease.
point, because
Right.
we waited to that point and they already had metastatic disease. So yes, some patients can wait to 8 or 12 PSA, but some patients may develop metastasis sooner. So I think, if they're on that continuum,
Right.
and you're confident of it, I'm not sure how much you gain by
And
putting that on.
we all see a lot of men with prostate cancer, so I think we can tell intuitively. It's the PSA doubling time. It's what we look at the effects of the primary tumor. It's the short duration of response the shorter duration of response to ADT. It's the shorter duration of time from primary therapy to relapse and things like that. All of those factors fit in and feed into our clinical intuition.
And to what Chris said, if it's a frail patient, if it's an older patient, you may delay it a little longer.
Yeah.
If it's a 55-year-old patient, you're probably going to jump a little sooner. So a healthy 55, yeah.
I used to say that is very important for us physicians, because it means there's very little chance we're going to be replaced by computer soon. Because that's kind of, here in a discussion like this, we would like to provide the perfect picture of the patient that we start on hormone, where actually the answer is, if you see these patients on a regular basis, if you see a lot of these patients, that's absolutely easy to decide we need treatment. Mm-hmm. Because that is that complexity versus clinical trial, where in clinical trial, you are in that steering committee, and the company is kind of forcing you to come with a combination or 2 or 3 inclusion criteria, which we know never describe the population well. It's like the high-low volume. It's the same. There are so many things beside that. But I think physicians should be reassured. If they use their corporate responsibility well, they know their job, they can tell you who is good, who is bad. The message is, if you believe the guy is bad, start the treatment right now.
Fair enough.
I would say that.
And
I think that's great.
One closing point I would say about this one, that biology is destiny, and the AR target is relevant. So all of this is clinically relevant, but it's also very biologically plausible. And the other notion is that little cancer is probably more sensitive than big cancer is biologically plausible. So it's consistent.
Well, where are we along the spectrum of AR amplification and all of those factors? We have no idea, because we're studying a disease. When we're talking about non-metastatic disease, we're studying an entity that we, by definition, cannot quantify, right, biologically. But we do know, for example, that enzalutamide was developed for the sole purpose of targeting AR amplification. And so it's actually kind of remarkable or notable that we're seeing benefits in the hormone-sensitive setting with these drugs, when theoretically there should not be AR amplification, which gets to the question, which seems obvious, but it wasn't intuitive, that these drugs would be beneficial in the non-AR amplified setting as well as in the AR amplified setting.
Well, let's get to that, because I think that's the other really big thing. That's the disease state we haven't created. That's the tumor biology that happens, naturally. And that's this metastatic, hormone sensitive. In many cases, initial presentation. In some cases, following local therapy. And we'll talk a little bit about the differences between those. But this is the disease state now that I think is really emerging for a greater and greater use of our androgen receptor targeted therapies. And I appreciate the underlying biology that you just brought up, and we should get back to that.